I'm very excited to welcome you all to National APAMSA Surgery Bootcamp. This is the third in our bootcamp series this year, and it's to be followed by the Family Medicine Bootcamp next Sunday. We have a very in-depth session in store for you all, geared towards providing lots of tips and tricks for medical students of all ages, all stages and ages, from being on the floor to the OR to studying outside the hospital. And we have a wonderful panel of residents, including Tej, Arlene, Melody, and myself, as well as an attending representative, Nance. So we're very excited that you're all here, and we hope that you're able to take away some clinical pearls from today's session. I want to give a big shout out to all from APAMSA, from our student leaders on the national board, including Kelly, Alan, Elise, and Jess, and to the alumni, including Kevin Han and Rui Hu, who've been involved in the creation of this series and its continued formation and progression. And so with that, I'll hand it back over to Kelly, one of our wonderful alumni co-directors, to orient you to today's format.
Thanks, Victoria. So like she mentioned, this is our third of 7 sessions in our bootcamp series this year. So we have family medicine coming up next Sunday, and then EKG, emergency medicine, and radiology after that. So the URLs to register are here. And then if you need any help registering, feel free to message me in the chat or email us alumni@apamsa.org. And then just some ground rules for today. While the presenter is speaking, the remaining speakers will be checking the chat box, so feel free to drop any questions there. And then if there's time for audience participation, you can raise your hand, and then when you're called on to speak, please announce your name, school, and year of training. This is just some outline of the topics we're going to be covering today. Really high yield for clinical rotations. And then we'll have some time at the end for a Q&A. And so we're just going to start by introducing our speakers, first with Dr. Nance Yuan.
Okay, great. Just unmuted. Hi, everybody. I'm Nance Yuan. I'm a solo private practice plastic surgeon in my 4th year of practice. Prior to that, I did med school at Johns Hopkins and plastic surgery residency at UCLA, and then a gender-affirming surgery fellowship at Cedars-Sinai. And I'm really glad to be here. Used to be very involved with APAMSA, with being president of my school chapter, and then also National APAMSA for 3 years as a community outreach director. So excited to be here.
Thank you. Next, we have Dr. Arlene Zhou.
Hey everyone, I'm Arlene. I'm one of the PGY4s from Carepoint in Jersey City. I went to school at Turo. I was involved with APAMSA at a local level, as well as National APAMSA. I was National Conference Director and also Hepatitis Conference Director. That's me right there with a little bit of liver, and next to it, my dog, Dango. Love him. So lovely to be here.
Thank you. Next, we have Dr. Tej Ganti.
Hello, everyone. I'm to talks. And during my time here, I was also involved in that. Yeah, it's been a wonderful experience. So here are just a couple photos of places I've been in the conference I went to in Australia. So got to see koalas. And I continue to be involved with APAMSA, as you can see in that top right photo. That was from the most recent national conference.
Next, we have Melody. Did Melody join yet? Okay,
I think she's still stuck on the subway.
All right, Melody is running a little bit behind, but she'll be here shortly. Just a little bit of background on her. She's from Dallas, Texas. She went to medical school at NYU, and she's currently a PGY4 orthopedics resident at NYU. Her APAMSA involvement included being chapter president and national sponsorship director, and her hobbies include dance, music, and eating her way through New York. And then last but not least, we have Victoria.
Hi, I'm Victoria. I went to school in Kansas City, Missouri, and then I'm a current ophthalmology intern at Oregon Health and Science University. And something I wanted to highlight just as I was looking through everyone's pictures is the involvement of APAMSA and just this organization is so wonderful. And if any of you are attending, really the relationships that you can form through this organization are wonderful. And I think that's seen through the pictures that we've highlighted. And so I included one of myself at the conference in Las Vegas. And I also just want to highlight all the people who've helped me get to where I am today. So here's a photo of some really important people in my life from my graduation. Thank you.
Thank you all for being here today. So we're going to go ahead and get started with the content.
All right, I guess we're jumping right into it. So here we have some pre-rounding tricks and tips, starting with just what to note when you're pre-rounding in the morning. So usually, typically you come in a little bit earlier than the residents, especially if you're already a part of the team, you know which patients that you're following. And usually what we kind of expect or, would want to know about a patient is obviously the vitals. It's listed just the way it is, like Tmax, given the max temperature that the patient had recorded. Heart rate in a range from this within a 24-hour. BP also within 24 hours, usually like, systolic as a range and then diastolic as a range. Respiratory rate, honestly, unless it's something that's like super crazy, like 20 something, 30 something, respiratory rate is not that that concerning. Obviously O2 sat, any desaturation episodes, and if a patient's like an ICU patient or it's ventilated, then you would need to know like the vent settings and also what kind of like a vent they're on, like is it BiPAP or is it mechanical ventilation? So those are the important things to note. And then in terms of labs, I don't know if you guys have heard of fishbone labs. That's usually a very good way to kind of organize, and that's how it's expected to be presented as well. So on the right bottom right there, you can see like examples of fishbone labs. The most common one obviously is the BMP. So once you get used to it, you don't even need to like write down like what they are. You just need to put the numbers and you know exactly what the values are. So sodium, potassium, chloride, your bicarb, BUN, creatinine, and your glucose. And then the first box, that's the two of most common. You have the white blood cell, hemoglobin, and platelets. Hematocrit, depending on your team, whether they really need to know or not, but usually the white count and the hemoglobin and the platelets would be sufficient. And then situational, a lot of people also want to know the just the micronutrients, so like the calcium, magnesium, and the phos. Those are important, especially on like a post-op patient and SICU as well. And if you have a patient who has like either liver issues or like gallbladder issue, then you would definitely need to let the team know about any of like the LFTs, the T-billies, and if it further breaks down to like direct billy or not, and alk phos. And also just if the patient is pre-op, it's good to know about their PT and just their coag status and their INR. So that's like a very good way to kind of organize how to write the labs, because when you have your list of patients, the space is limited, and you really need some ways to kind of organize everything. And if a patient's vented or was having a desaturation episodes and had an ABG, that's something that is of note as well, and that's usually how it's presented. You don't have to worry, like that's usually how the ABGs are listed on the chart as well. So you just need to literally copy the exact values, and it's already in that order. And then of course types of study, like if a patient had any CT scans or like HIDA scans or chest x-rays, or even just like for like an SBO patient or an abdominal x-ray, that's something that you need to know. So what like brings you above and beyond is know the indications of why these studies are being taken, instead of just know like, oh, the patient got a CT scan. Like if you can express like, oh, the patient got a CT scan because of this reason, then that's like an extra point. And of course, with the type of study, you need to know the results of the study. If the read's not back yet, you can be like, oh, the read's pending, or you look at the scan and this is what I kind of see, and you can go over with the resident prior to rounding as well, and know any changes and the significance of the study, why it's being done. And then, of course, note any overnight events, like I said, like desaturation episodes, any procedure was done, like if the patient got an IND or if another service, let's say, did a cardiac cath or like a echo, or ortho took the patient, anything like that, that needs to be noted. And if the patient had any drains, you need to know the output, like NG tubes, JP drains from like a surgical drain, all of those, or like even just as simple as a Foley catheter, you should note down, the outputs and the intakes as well. And of course, the AMP is just your assessment and plan. So that's usually how, like, what are the things that you should look out for. There are more in-depth ones like medication and stuff like that, but those are usually what your teams are looking for and what the patients are in the hospital for. We'll go to the next slide.
Yeah, so let's go. Yeah, so Arlene already did a great job of talking about like the pre-rounding and everything. So as kind of was already mentioned, just make sure you leave a lot of time to do your pre-rounding, including the content that Arlene mentioned, and you're preparing your lists. And a lot of times med students are asked to follow certain patients, but just keep in mind that if you're on a sub-I or on a rotation, you can always follow more patients, and it's actually best if you really understand the care of every single patient that's on the team. Obviously, if there's multiple med students, you want to play nice and don't be looking up things on the other students' patients. But if there's a patient that's uncovered, it's always best for you to know as much as possible about as many patients as possible, because the intern has to do that too, right? So you always want to behave as if you're one level above wherever you are. So if you're a med student, you really want to be functioning on the level of an intern. So pretty much know everyone that is on service. Yeah, next slide, please.
So I think there's a question why AMP is an overnight event. So I put it there because your assessment and plan can change depending on the overnight events. So let's say like a patient is supposed to go to the OR, but overnight like desatted or had like an overnight event, and now your assessment and plan may be different. So that's why I put it in that area. With that being said, we'll just kind of jump to oral presentation. It's always presented or most likely presented in the SOAP format. And for those that are not familiar, SOAP is subjective, objective, assessment, and plan. So as a medical student, as you get more comfortable with the team or even as like a sub-I, you may be asked to go and see a consult. So when you see a consult, you see a patient, you want to present it in a precise way, but also not too long that, there's like a saying that surgical residents have the attention span of a goldfish. So try to be concise, but get all the information across. So you always start with age so that we know what kind of population we're working with, female or male, and then any pertinent like past medical history, past surgical history that may contribute to the HPI. And then you will present, the HPI, whatever you ask the patient and what kind of background information you can get from them. And then obviously any pertinent exams that's related to diagnosis. Like let's say if the patient comes in with like a GI bleed, like you need to know if they had any scopes in the past. And then also you would need to include like lab values, whatever they came in. Do they have a white count? Do they have any elevated LFTs? What are their, again, like if they come in with a GI bleed, what are their hemoglobin? And then any imaging finding, if there's any CT scans, X-rays or ultrasounds. And then you will move on to, so those would be like the subjective would be the HPI and any pertinent exams. And then your objective would be these lab values, imaging findings, and then always you do a physical exam. So that's also very important as well. And then after that, you end your presentation with your assessment and your plan. And then similarly with rounding, if it's a new patient, your team's not familiar with this, it's kind of similar to the console, but just a little bit more concise. So like, age, and then gender, pertinent, past medical, past surgical, and whatever the HPI is, just like a brief history. You don't have to go more in depth like consult. And then it would be like on presentation, patient had lab values of this, imaging findings of this. And then you would go into the overnight events, like overnight the patient had a febrile episode, or if there's any new imagings, any eyes and O's. And then you pretty much always end with like PE findings and any pertinent plans. Let's say if the patient has to go to echo, then that would be part of like the pertinent plans. And then obviously you end your presentation with assessment and plan. If it's a known patient, recurrent patient, patient's been there for a few, for a few days already, you don't have to go into like the past medical, we already know, right? Like the team's already familiar. So you would still kind of say like, oh, a 21-year-old female or whatnot, presented with, now you just give like a diagnosis instead of like an extensive HPI, you just be like, oh, the patient came in with GI bleed. And if there's any operation that was performed, you should know what's the post update and what operation was performed. That would also, if it's like a post update 1 or 2, good time to mention if any acute events happened during the OR. And obviously any overnight events within the last 24 hours, any new imaging, I's and O's, labs, vitals. And then, like I said, you always end your presentation with assessment and plan. So if you go on the next slide, I have like kind of like a sample one. So let's say you have a consult for an acute API. And so you would say like a 21-year-old female with past medical history of a left ovarian cyst and UTI, and no past surgical history, you present it. So the subjective would be a right lower quadrant pain for a day with nausea and vomiting, reports of anorexia, no prior similar episodes, denies fever, chest pain, shortness of breath. And something pertinent is that because she has the ovarian cyst in the past, you would mention last menses was like a week ago. And then on objective, it would be like on presentation, patient with leukocytosis of 16 and left shift. And then you have CT finding of 13 millimeter dilated appendix with fat stranding. And you would mention the vitals, afebrile, vitals is stable. And then on exam, patient had left lower quadrant pain and roxane sign positive. So that would be like enough for an objective. And then you would go, your assessment would most likely be 21-year-old female with acute appendicitis. And your plan is, what you would develop for this patient. Usually for appendicitis is NPO, IV antibiotics, IV fluids, and plan for a lab API. So let's say this consult came in like late afternoon and the patient doesn't get operated on until the next day. And so in the morning when you're rounding, the team is not familiar with the patient, or someone post call now comes back and needs to know this patient. So again, you said the same thing, 21-year-old female, past medical history of ovarian cyst, UTI, presented with right lower quadrant pain, nausea and vomiting and anorexia. So it's like a shortened version of the subjective. And then the finding, the objective finding would be presented, the patient with leukocytosis in left shift and a CT finding of a 13-millimeter dilated appendix with fat stranding. Then you would go into no-Q overnight events. Patient reports improvement of pain. So that's what happened in the past 24 hours since the patient was admitted. And in terms of vitals, you would go through that whole Tmax and everything. So I would suggest like at the beginning, because you don't have that relationship with your team, I would just say all the numbers as is, but usually your rotations like at least 6 weeks or whatnot, and by the end of like the 3rd week, you already developed that relationship. A lot of people may be comfortable with you saying like vitals are stable because they can trust you to evaluate the patient to know that the vitals are stable and nothing crazy. And then you continue with your exam. The patient still has right lower quadrant pain, things like that. And then your assessment obviously still the same, right? 21-year-old female with acute appendicitis, and plan same thing, but OR for today for lab API. So let's say they go to the OR, it's perforated, so they have to stay for at least another 72 hours for IV antibiotics or so. And so the next day, you're rounding on this patient. So now the team already knows this patient. You've been following this patient. You can just say the 21-year-old female presented with acute appendicitis. Like we don't need to reiterate her past medical history, right? And you would add it's a post-op day 1 status post lab API, and then acute like OR findings will be found to be perforated in the operating room. And overnight events, overnights the patient had diffuse abdominal pain, no nausea, no vomiting, and is tolerating diet. And the objective patient was febrile, the Tmax is 101. but responded to Tylenol, and then you would, state your vitals. And then on the exam, patient had incisional abdominal pain, and then you would also describe the incisions, clean and dry, like no redness, or if there's any like redness, or if there's any discharge, that would be a good time to say it as well. And then no additional imaging, and there's a drain, so you could say like drain output, the amount and also the quality. So is it serosanguinous? Is it serous? Is it sanguinous? Or is it purulent? That's also very important to note as well. And so your assessment would be like 21-year-old female with acute perforated appendicitis, status post-lap API with drain, post-op day 1, and your plan now change to regular diet and continue IV antibiotics and monitor for drain output. It's a little bit of a busy slide, but I hope it gives like an example of what a good like oral presentation or is expected when you do like a presentation in the morning.
Okay, so with that excellent review of an assessment plan by Arlene, this slide basically ends up being all the things that you're following because they directly feed into your assessment plan are the things that you as a medical student patient should be keeping track of. And the kind of left versus right is just there's certain things where you need to actively be trying to get a hold of someone immediately when a patient is acutely not stable or there's a critical result, right? Whether that's labs, vitals, their exam changes, something that becomes a patient safety issue. Things related to the patient's discharge planning, like, for example, your ability to advance the diet, those sorts of things you might be able to just notify the team the next time you see them. Next slide.
Okay. Yeah, so just to kind of piggyback off of Arlene and Tej, I think for the in talking about what your role is on the team, which I think a lot of times is the hardest thing on surgery rotations, is remembering that you are a team member. You're not just a med student, you're not just there to shadow and to have information fed to you. You are also part of the medical care team. Okay, so you should always be thinking about how to advance care, appropriate to your level, of course, and communicating with the rest of the team. And you're not just shadowing. So, like Tej was saying, you're always triaging. You're looking out for changes for the patient, and if there's updates, you're letting your team know, and obviously triaging that a little bit. Where if there's something very time sensitive and urgent for patient care, that you give that information at the appropriate time. Whereas if there's something that's less time sensitive, you can maybe choose, a better time to update someone. And as long as the patient is safe and you're communicating, you're never doing too much. So that's just an important mindset thing to get out of the way, especially for students going from preclinical studies to the actual clerkships. You're always actually a team member. So for rounding, and then again, great thoughts from Arlene and Tej. So a lot of times it depends on the actual team, but a lot of teams for surgery will do some form of sit rounds first. Well, they'll go over the list and go over updates. Usually that's kind of when you're presenting, and then you'll actually physically go over to the rooms and see the patients together. Depending on the team, some people will do those presentations that we talked about just kind of at a table somewhere and then go see patients versus sometimes teams will have you go to the rooms and then do your little presentation at each room. So you kind of, see the vibe of whichever team you're on. And Arlene did a great job of going over SOAP format. That's just a good thing in your head to think about, okay, what is subjective, objective, assessment, and plan? And it's also important for writing SOAP notes. But from a practical standpoint, again, you'll see kind of how other people and how the residents are presenting on the team. I think there's going to be times where the presentations are even more abbreviated than that. So, for example, subjective, textbook is definitely to do, 21-year-old female, post-op day 1, status post-acute API, but depending on how quickly you see rounds are going, sometimes, if let's say it's a smaller service and people are already very familiar with the patient, you might skip certain things. Like maybe they're like, okay, we already know exactly who this patient is. So you might even skip some elements like saying they're a 21-year-old female because everybody already knows who it is. You might just skip ahead to go post-op day 1, status post status post API. And then the other clarification, because there was a question in the chat, was about the assessment and plan. Most of the time for an oral presentation, because it really is just like chatting, with your team, you probably are not going to rehash. In your note, you definitely will, when you're saying in your note, assessment and plan, 21-year-old female, status post acute API. But for a presentation, you probably are not going to say the same line again, just in the interest of time. But I think just both for presentations and rounds, an important part for us, the assessment part, is really to put your assessment, which is your clinical judgment as a physician, because and I see this a lot on notes, where people write, just status post API. That's fine. It works as an assessment, but you can take it a step further and remember to put your clinical judgment about what is the status of that patient. So if the patient is stable, the assessment is really, it's 21-year-old female status post API, comma, doing well. It can be very simple. If they're doing well, and they're stable, doing well, stable, something like that, to show after you put all the information together about the history, what happened overnight, their vitals, what is your assessment? It's that they're doing well and they're stable. And because the opposite could be true too, right? They could be, showing signs of infection. They could be becoming septic and unstable, so in need of ICU. So remember in both presentation and notes to really add that element of, your judgment, in just a couple of words. As a med student and or intern, remember that, if you're given permission to do this, you're the leader of the rounds. So again, if you're just a third year med student, maybe this doesn't apply so much, but especially on sub-Is, if you are basically expected to act like an intern, you really want to be leading rounds. And one very small point to do this is to actually plan out which rooms you're going to go to and walk ahead of the team and lead the team to the rooms. It seems like a very small thing, but it actually makes a big difference because people are trying to get to these rooms efficiently. So you're a tour guide, actually look at where the rooms are on your list and think about, well, what's an organized way you're going to bring people in the most efficient manner possible. It could be that you're seeing the most acute patients first. Like, let's say there's some ICU patients. You go to the ICU first, and then you do the other patients later. Or a lot of times, if the service has patients on multiple floors, it's really common to do gravity rounds where you'd say you go to the top floor, then you go to the next floor down. And it's just an efficient way to make sure you're covering everybody. The chief resident and the attending, they just want to be talking and thinking about patients. They don't want to be looking at the paper and figuring out where the rooms are. So it's actually very helpful if you are the tour guide and you lead them to the room. That was feedback that I got in intern year. And I was like, why does it matter where, because one of my residents would say, walk ahead, walk ahead. But, especially when I became a chief resident, I realized how important that is. Next slide. And then already great presentations on rounding. Yeah, again, as you move forward, very likely it's going to be helpful to abbreviate these presentations. For example, like Arlene was saying, vitals within normal limits, something like that. But very, very important is that you actually go over all the numbers and that you don't miss any details. You cannot say vitals stable if someone spiked a fever. You really have to point that out. So definitely know what is considered normal or not. And if it's borderline, you can say that. If it's like, oh, they had, they had, one episode of like SPP 89, you can say that if it's borderline and you're not sure if it's normal, go ahead and put that in. But if someone realizes that it wasn't normal and you said it was normal, you lose a lot of credibility. So just make sure everything is correct. And I think the rest was discussed already. But again, ICU patient, make sure you also include stuff about, vent status, pressors, drips. And for med students, I think it's a good idea to also check plans and events with the intern before rounds, because sometimes they will obviously be getting pages that might not yet be in the EMR. So for the most updated information, you should probably run things by the intern before you officially present. Next slide. So for rounding, again, with that same concept that you are a team member facilitating care, think about how to be efficient. Do not stand in the back in the corner just watching. So one really easy way to look involved and to actually be involved is when you go into a room, you can be the one that is, doing that initial knock, going into the room, immediately beeline to where the gloves are and grab gloves for yourself and the chief resident or whoever is his lines rounds, whoever's running rounds. Um, so grab gloves because that shows you're already, ready to go, ready to assist with the patient hands-on, and then beeline to the head of the bed where the patient is to be ready to help with dressings. And I know as a med student, especially early on, I had to learn this as well. Sometimes people are like, oh, well, I don't want to get in the way. I don't want to interfere. But it's actually the opposite. If you go right to the head of the bed and you're ready to help, it's actually facilitating rounds being done a lot quicker. Med students usually are going to be the ones that are expected to have all the dressing supplies on hand. So some teams may have you carry a little bucket with the supplies, and then for those of you that have already started doing rotations, you'll know you have to stuff your white coat pockets with tons of supplies. It's understandably very stressful for med students because, so you do have to anticipate a little bit what is going to be needed, scissors, 4x4s, but depending on the type of dressing, right? Maybe it's Curlex, maybe it's Xeroform. So try to anticipate what kind of things are needed. If you're not sure, you can always ask the intern, but it's so much responsibility on the med student, but a lot of the chief resident is not going to be carrying this around. So it's always a total bummer when people are changing dressings and they're like, I just needed one more 4x4. And then unfortunately that blame gets put on the med student. If only you had put it in your pocket, so you just want to be ready at all times. And if you don't have it, also just familiarize yourself with where you can get it immediately because that kind of thing does hold up rounds. So always try to have that ready. Um, and yeah, and usually a lot of times, depending on the service, sometimes it's a small team, sometimes it's a big team. But if it's a bigger team, a lot of times there's like mid-level type of residents. Um, I guarantee you the resident and even the intern, they don't mind standing back and watching you help with dressings. Like they usually, maybe whoever's leading rounds can do the dressing with you and examine the wound, but the other people are totally fine with watching in the back. So if you're in front doing the dressing, then everyone can visually see, oh wow, the student is very involved. They're doing a great job. They're not afraid to get in there. And people appreciate the work that you're doing. And if there's for some reason another resident needs to get in there, don't worry, they will let you know. So don't be afraid of doing too much. Just obviously be mindful of, if someone asks if it's a sensitive exam or something, someone will let you know. Okay. And then the other thing is for talking, just let the senior talk. I remember when I was a med student, there was a point where I was like, oh, I tried to like chime in a little bit. Just don't. And then my chief resident was like, don't do that. Because it's confusing for the patient, right? If there's like multiple people they're talking to. So, be hands-on and ready to help, but talking wise, just let the senior do it. Next slide. And then in terms of clinical work, so we talked a little bit about kind of those sit rounds. I think a really important thing is that for every single patient on the floor, now, again, don't step on the toes of your other med students, but just for your own learning, you should be writing down the plans and to-dos for every patient. So normally you get a list, right? So write down what is the plan for that day? CT scan? Is it getting a consult? Is it taking out a drain? Write down the plans because first of all, that's really good for learning for yourself to understand, well, what is the patient even doing in the hospital, right? Because even from an insurance standpoint, right? Like we never keep people in the hospital just because there's always something that's happening. Is it that we still need to work on their pain control? What is it that's keeping them in the hospital? So it'll be a lot more fun and engaging for you to even understand what is going on with the patients. But then once you have that list, it's also so great for figuring out how you can be helpful for the rest of the day. So now you already have the plan, and instead of just saying to the resident, hey, is there anything I can do to help? a lot of times when you ask that, the resident or attending, they might just say, oh, it's okay, because they're too tired and busy to tell you what you have to do to help. Like by the time they told you, they would have just done it themselves. So it looks a lot better if you're aware of exactly what the plan is, and then you can offer specific help and say, hey, I saw that, so and so needs a GI consult. Would you like me to call GI? Hey, I saw that so and so needs a drain removed. Is it okay if I remove it? And again, maintain close communication, because sometimes they may want to do it themselves, or maybe they feel more comfortable doing it themselves, and that's fine. But even if they don't have you do it, they'll know that you know exactly what is going on, and that goes such a long way towards actual patient care, but also their impression of you, and also that eval, because it shows that you are, even if you're not on your own doing everything yet because you're more junior, but it shows that you're ready to help. You know exactly what is going on. um, and then for some of these tasks, when you're early on, they may be new for you and you might not be totally comfortable yet. But I think it's a great way to learn. So if there's something you're not totally comfortable at yet, you can also communicate that. So for example, you could say, hey, can I help call GI? But maybe I'll do it. But maybe you run by, you discuss the question. Oh, just confirming the question we have is blah, blah, blah. So it facilitates, an additional conversation with your team, just so that you're totally clear what you have to ask. Um, the other thing you can do is maybe you can call them like with your resident right next to you. That's another option too, so they can hear everything you're saying. So that's an option. And then for something like like removing drains or something like that, if you've not done it before, then tell them like, hey, can I help remove the drain? But I haven't done it before. Can you show me how? And maybe you get all the supplies ready and you do it together. So it's just such a great way to learn. Another option is, updating a patient or updating a family about something. Again, a lot of times the residents and interns are running around doing things. They're going to really appreciate if you do these. A lot of times because they're triaging and doing the most time sensitive things, some of the really helpful like patient care things, like just communicating a little bit more with the patient, or getting the translator or something like that. Those little things that are so important for patient care do get missed a little bit. So I think, again, offering to do that. Oh, let me tell the patient that we're doing this. Like that goes such a long way. And then again, if you know that there's labs pending, and you know that, hey, the team was waiting on that information, look it up in the EMR and say, oh, so-and-so's lab came back, it was this. And so just knowing what is on the docket for that patient and what has to be done is so, so important. When Definitely help with notes. Not everybody, these days, I think the trend is that there's a lot of people that just prefer to do it themselves because they think it's easier and they don't want to like correct your work. But I think it's really helpful for med students to learn to write notes. So definitely offer to do it. And again, and even if someone says no, it's okay, at least they know that you offered. But when you are writing notes, and this is true for physicians of all levels, be careful of copy paste functions. These days in EMRs, there's a lot of like templates, copy paste functions. They do make life easier, but you have to read through every part of the note before signing. I can't tell you how many times I've seen patients that are like totally awake, ready to be discharged, and their exam note still says they're intubated in the ICU, intubated and sedated. So just from a liability standpoint, it's good practice to make sure to be very, very careful about things like that. Next slide.
So I always tell the medical students, be proactive but not too eager. Being proactive, like there are things that medical students can do. So like a diet check, if we advance the diet, right? Like, so that's something that you should write down on your list. And it'll be super helpful to the team if during lunchtime when it's like, oh, I saw this patient, she's eating fine. She tolerated her diet, or like a void check or things like that. Like things that doesn't need to be physically doing something. Those are the things that you should be writing down. And so that's when you're being proactive. When you're doing things like, oh, can I do this diet check? Like, obviously, that's something that you should be, listed, but that's when you're being eager, like, oh, I'm going to be doing this, I'm going to be doing that, telling them. So be proactive, get things done, and then update the team as needed. But don't like make it be like I'm gonna be doing this, I'm gonna be doing that. I think that kind of leaves like a bad impression for the team. Um, when it comes down to it. But definitely just, I think the more of it is just be in a close communication, especially with your interns, because at the end of the day, um, you're a medical student. Anything that happens, liability still goes from the intern up to the residents, like, the attending, that goes up like that. So being close communication, because sometimes plans might change and intern might know, and you're still under the impression that we might pull this drain, and then you go and pull the drain, and that's not the plan. So always be in a close communication.
Yeah, absolutely. Yeah, yeah. So yeah, absolutely. Because there are horror stories. We'll talk about horror stories later too, but um, do not just go rogue and do something on your own for sure. So things that are more like hands-on like that, like definitely confirm, if you're doing it. But like Arlene was saying, like checking on a patient, are they tolerating their diet? Checking in with the patient's nurse or the patient themselves. Like that's such a great thing that you can do, and then you don't have to, just in the because they're busy, you don't have to necessarily say, I'm going to go to, that's pretty non-invasive to go check on a patient. So you can go ahead and do that and then update them. Yeah, great point. So next, let's talk about the OR. Next slide, please. And again, I think surgery rotation is tough for med students because you're not the actual direct surgeon. But I think a good, just as a mindset thing, again, still remember that you're a member of the team. Every single person in the OR is a member of the team. And it's hard to kind of get used to that feeling because you feel like you're not obviously not doing the surgery. Um, but remember, you are still a team member that's facilitating the surgery, and you're help you even though you're technically not doing like the actual key parts,
Yeah.
you're still facilitating, just like the surgical techs are facilitating the surgery, just like the nurses are facilitating the surgery. So you want to think about how to make the case go as smoothly as possible. And and you at a junior level, you're not going to be quite ready for this yet, but pretend you could be the understudy for the attending. This is also important when you're a resident too. You want to pretend like you could do the surgery. So you will talk about study tips later, but you want to just prepare for the case as much as possible and be an educated assistant. Even scrub techs and nurses, they do educate themselves on the cases so that they can help as much as possible. And so one quick thing also is being in the OR before the case starts. So, you don't want to be lagging behind the team. So you should physically be in the OR. This is true for residents as well, before the case starts, and then let the attending know when the patient is in the, that's more for residents, sorry, but you let the resident know when the patient is in the room. Okay. And then interns will be doing more orders, but remember, you're not just shadowing the intern. So if the intern's doing orders, you're not just hovering around, sitting there. Always think about what could you be doing to help. So when the patient rolls into the room, you can help transport the patient, to it. Usually you have to move a patient from the gurney to the OR table, and the nurses need help with that. So you can help with that. And if you help with that, the intern actually has more time to put in orders and do other things to prepare for the case. So, and then also this is maybe a little bit more for interns, but, each surgeon will have preferences for how they want the patient positioned. Like, is it going to be on arm boards? Are the arms tucked? What extra padding is needed? I don't think med students usually the med students not deciding these things, but pay attention to what people are doing so that you can help with it. And then residents also plus or minus prepping too, because at some places it's helpful for the resident to prep. I don't think med students will ever be expected to prep, but just know what's happening and so that you can assist. Next. And then during the case, this is where the pre-case preparation is so important. You really need to pay attention to the case and the steps of the case. And if there's anything that you can do to help, again, at a junior level, it's not going to be as much as the first assistant. There might be some rare instances where a med student is first assisting, but students will always usually are going to be the ones cutting suture, right? So if you see someone's tying something, that's going to need some kind of suture, some kind of scissors at some point, right? So you can ask for scissors. Can I get suture scissors? But always ask Do not grab from the Mayo stand, okay? The scrub techs and nurses are very, very particular about that because they're keeping everything in a certain order, and it's just really bad etiquette if you're grabbing. So always ask, and then it's okay. And then also for chatting in the OR, keep in mind that, sometimes these are long cases. People want someone that is just personable and kind of, fun to be around. And it's okay to chat and ask educated questions and have a conversation while we're doing surgery most of the time, because a lot of times there's parts of the surgery that are more routine and it's totally fine to talk, but also read the room and the mood. So there's going to be times where everyone is more relaxed and talking, and that's a good time to bring up any educated questions you have. Um, but do not, sometimes, like, let's say something happened, there's a bleeder, and the attending and the resident are actively trying to stop bleeding. Obviously, that would not be a good time. It's okay for it to be quiet sometimes too. Like, don't if someone is concentrating on a very difficult part of the surgery, do not try to insert questions during that time. It is okay for everyone to be quiet and just focus. So you'll get a sense of kind of like, it's important to have some, social skills in terms of that, kind of read the room a little bit, get a sense of where we are at in the surgery, to decide, when it's a good time to talk. But when it's a relaxed time, totally fine to ask questions. They should be educated questions, okay? Like something that shows that you actually know what's going on. And again, this will tie into the study tips later, but for example, you can ask about, if you've read some papers on that surgery, you can ask about some alternate techniques for doing a certain part, or, maybe ask about why certain instruments are chosen or not others. But it looks really bad to ask something that shows that you're totally uninformed. For example, we'll get into horror stories later, but there, as I'm a plastic surgeon, and when I was in residency, sometimes med students would come into cases late because of didactics, which is totally understandable. But we were doing a joint case with general surgery. They were doing mastectomies, and we were doing an immediate breast reconstruction, taking a deep flap, which is tissue from the abdomen, at the same time. And a med student came in and was scrubbed in with the breast surgeon and asked the surgeon, "Oh, is this patient going to get reconstruction?" And we were literally in the room doing the reconstruction at that time. So that just shows like very poor awareness of what's happening. So you always want to ask educated questions. And then one other thing is, sometimes in surgery, it's going to be kind of maybe a more fun, relaxed vibe. Sometimes people will be playing music. And sometimes even the resident or the attending will be like maybe singing along a little bit or something. I mean, I think that's not that common, but sometimes people might. I would, especially as a student, also as a resident, just avoid humming or singing. Like you might think like, oh, let's like sing along, it's fun. Do not sing along. Um, sometimes that can be irritating, even if you're a great singer, sometimes it can be irritating for people when they're trying to focus. And there was actually one of my senior residents would do that. He would like hum a little bit under his breath. And uh, behind his back, there was an attending that complained about it so much, even mentioned it after he graduated. So just don't be that person. Just, it's not the time for karaoke. Okay. Next, I think, is that it? Oh, sorry. And last thing is obviously maintain the sterile field. That means keeping your arms always and hands between your neck and your waist, right? And just be very, very mindful of that. If someone is operating, you're looking at the field. So if they're working out of the lights, or sometimes the lights kind of float around, adjust the lights. That's something you can definitely do. Retract. If you see someone struggling, something, maybe there's like some tissue that's getting in their way, retract. You can ask for an Army Navy retractor. You can maybe use some AdSense to pull things away. If you're not sure what type of retractor is helpful, you can offer. You can say, hey, is it helpful if can I get an Army Navy in here? Is that helpful for you? You can say something like that. Cutting sutures, just as, there's a joke that's like, oh, med students should just ask, would you like your sutures too long or too short? Because as a med student, it's kind of easy to not know exactly what people want, but you can always ask. In general, knots inside the body should be cut with a 4 millimeter tail. okay, or external 4 mm tail, because in general, if it's possible, we want to leave a little bit of a tail so that it's not so easy for the knot to unravel. But sometimes you want the knots cut short right on the knot, and that's usually the case where the suture is buried, meaning right under the skin, like for a dermal or subcuticular knot. You don't want the tail sticking up, through the skin. That's going to cause a wound healing problem. So in general, like if it's away from from the surface of the skin, 4 mm, but if it's right under the skin, right on the knot. But when in doubt, ask. Suction, that's always a great task for a med student. You could be suctioning smoke, you could be suctioning blood or fluid. That's affecting visualization of what the surgeon is doing. But again, when in doubt, ask. And sometimes there might be a very, very, let's say a very delicate sort of area, like let's say they're working on a nerve repair or something like that. That or very tiny vessel, just ask what's helpful or where to place the suction, and just be mindful that you're not causing trauma with your suction. But in general, it's very helpful. Tying in drains, a lot of times people will have students do that, so you want to be comfortable doing that. I would recommend getting a knot tying kit to practice your tying. And then students can also help with closing, deep dermal layer and subcuticular layer usually for students. And then at the end of the case, you can always help with cleaning the patient. Like that's when usually the resident is, they have a lot to do. They need to put in orders for the patient, things like that. So you can help a lot by helping the resident and nurses clean the patient, put on dressings, grab the tape, whatever it is they need. Next. Is that it? Okay. Yeah, and so again, going with that same concept of being an understudy, ready to take on any portion of the case, because that will help you be really prepared. Leon?
I just wanted to jump in and add one extra thing in terms of the just being in the OR and being effective in the OR. Something that I think maintains among all surgeries and all surgical subspecialties is really the first time that you work with an attending, you pick up on little things that differ. And so using those tips and tricks for the next time, if you're really focused on the details, I think can help you stand out. And so just to provide an example, I guess, from a microsurgery perspective, I think something I found really interesting on my ways was every single ophthalmologist I worked with had a different way that they like to cover the eye after surgery. Some people like to tape, some people like to put the positioning differently. And knowing the way a certain attending does that, I think always helps. It makes you stand out. And there's a lot of things that you'll notice when you're in the OR. Head positioning, the way they like you to cut. There's so many little details that if you're really knowledgeable and focus in and just pay attention, it'll help you stand out the next time you work with that attending. So any med student, if you can just pay attention to the details, that'll make you a really good helper in the OR.
We're going to take a 5-minute break.
I'm Melody. Nice to meet everyone. Thank you all for logging on a Sunday. So now we're going to go over some general tips for trauma and for being in the trauma slot. So most of y'all, regardless of what specialty you're going into ultimately, we'll be doing rotations on trauma. And some of y'all have probably already done a trauma rotation as a clerkship student or as a sub-I student. So for those of you who are not familiar, you can click whoever's controlling it. Oh, yes. The trauma slot can be a really chaotic and really scary place, especially if you're not as familiar with how things run. So things are going to be very fast paced because these are some of the most acute patients coming into the hospital. So these next couple of slides are by no means comprehensive for your trauma education, but it's just to give you a taste of what you can expect and some common terminology. And then we'll conclude with a little case scenario at the end. And at that point, audience participation is encouraged. Next slide. So for some basics, you always want to start with the alphabet, your A, B, C, D, E's in particular. So A is airway. You want to check that the airway is patent, remove foreign objects if you see them. Sometimes the patient may need to be intubated in the slot if they cannot protect their own airway. B is for breathing. You want to make sure the patient is ventilating and oxygenating well. One click, please. This is where it would be helpful to look at the vitals, look at the respiratory rate and the O2 sat. Some things that could cause issues with breathing include perhaps a pneumothorax, a hemothorax, malpositioned ET tube, or a flailed chest in a patient with significant chest trauma and multiple consecutive broken ribs. And C is circulation. So a big term here is hemodynamic stability. So how does the blood pressure look? How does the heart rate look? And if they are abnormal, what could be causing this abnormality based on the patient's presentation? Click here. So here you're going to start thinking about the different types of shock. Is your patient someone who fell down a flight of stairs head first and you suspect a neurologic injury, so neurogenic shock? Or is your patient someone who sustained multiple stab wounds and is actively hemorrhaging, so hypovolemic shock? Click here. You're also thinking about getting access for resuscitation. Classically, we are taught that patients should have 2 large bore IVs, for example, in the antecubital fossa regions. And if you cannot, you're going to start thinking about an intraosseous access rather, or access in other regions of the body. So TLDR, you're going to see bleeding in the trauma slot. And when you see bleeding in the slot, you should be somewhat familiar with recognizing how bad it is. One click here. There are actually stages of hemorrhagic shock based on the patient's vitals and other parameters like urine output, blood pH, and mental status. So the worse these parameters are, the worse the patient is doing, and the more aggressive you want to be for patient resuscitation. Click. You're going to hear things like massive transfusion protocol, or MTP, a Belmont machine for rapid infusion, and a 1-to-1-to-1 ratio of transfusion for red blood cells, fresh frozen plasma, and platelets. Next is D for disability. So basically, how is the patient's neurostatus? Click here. So you're going to hear GCS a lot. That's the Glasgow Coma Scale, which is a composite score based on eye-opening response, verbal response, and motor response. So max score is 15, and the lowest is actually not 0, it's 3. And with a GCS of 8 or lower, people will start talking about intubating the patient to protect their airway. And last but certainly not least, you have exposure/environment. Click here. So you will be taking off the patient's street clothes. So get yourself a good pair of trauma shears, and I promise you these shears will come in handy even when you're not in the slot, no matter what surgical specialty you're going into. And you can be helping to move the patient onto the stretcher and with log rolling, so the whole patient can be examined during primary survey for obvious injuries and deformities. Next slide. So some other things that could be done in the slot include imaging. Click here. So an EFAST ultrasound exam will be performed usually by the ED team to check for free fluid in the abdomen. If the patient is going to go emergently to the OR for an XLAP, they probably have a positive EFAST exam. A portable chest x-ray and often an AP pelvis x-ray will be performed in the slot to check for chest injuries and for pelvis injuries. And next, when you hear the phrase pan scan, that usually means a CT, and usually without contrast. These images will usually be decided upon and ordered for the patient before they even leave the trauma slot. So a pan scan can include of the head and neck, as well as chest, abdomen, pelvis, as well as the C, T, and L spines. And finally, depending on the injury mechanism, there might also be what I'd like to call the specialty scans that could be ordered for the patient, such as a CT angio or CTA if you suspect a vascular injury, CT of the lower and upper extremity if there's a bad fracture, MRI of the brain or the CTL spines, or even a CT urogram if there's a suspected injury to the bladder or anything more proximal. And this is where your consulting services come in, like ortho, neurosurgery, urology, etc. In addition, people will be running around drawing a slew of labs like a CBC, a BMP, VBG, glucose finger stick, talk screen, etc. And sometimes patients may need medications, for example, for sedation, if they're agitated or if they need to be intubated. And sometimes antibiotics will be started right away in the slot. For example, if the patient has an open fracture where the bone is sticking out of the skin. So really pay attention to all the things that are going around you as much as possible so you can learn as much as you can. And you want to make sure you're familiar with some of the procedures that might happen in the slot. Click here. So placing a Foley catheter is something that's done often. Click here. Placing a C-collar is usually done unless, proven otherwise. Usually the trauma team needs to clear the patient of the C-collar if they don't have an injury, but usually they come in with one already. Click here. Chest tube sometimes as well. And then another click. And you should know what an endotracheal tube looks like for patient intubation. And one last click. And does anyone happen to know what this orange contraption is? You can sound off in the chat if anyone knows. Is anyone on the yes, that's right. For the pelvis, that's right. It's a pelvic binder that sometimes is placed when the patient has a bad pelvic injury and an unstable pelvis. And then finally, for the slide, you sometimes will be a part of or help with the secondary and the tertiary surveys. So when you're rotating on trauma, you might be involved with examining the patient again to make sure that less obvious injuries, kind of after the fact, after the major injuries are addressed, are not missed and are left untreated. Okay, any questions at this point? Okay, if not, I will hand it over to Arlene for the next slide.
So that was very comprehensive overview of when a trauma comes in, and you're probably wondering, what can I do as a medical student? So know your role of where everyone is, and because the trauma bay is a very high speed and a very chaotic space. A lot of patients are in a lot of urgent need, and you have a lot of teams there. You have the ED team, the trauma team, the EMT who's dropping the patient off, and most of the time, if it's a code, anesthesia, respiratory, and also other consultants like Melody mentioned, neuro, ortho, and neurology, etc. So, what can you do is make sure that when the trauma is called, that a lot of the things are there, right? So when as a 3 or 4, when I respond to traumas, I make sure we have the ultrasound ready to go, because we have to do the EFAST exam. We have to make sure that the X-ray is already being called, already, is already on the way. If it's a code, make sure that the blood is there. Familiarize yourself with where all the supplies are. Know that if the attending or the resident or anyone on the team asks for dressings, asks for central line kits, know where the chest tube kits are. And just familiarize yourself with where everything is, so that it can be a more streamlined and efficient way of running the trauma. And obviously, when you're running a trauma, it's the same thing as running a code. There's one person that's calling things out and dictating what everyone is doing, where everything is going. So pay attention. Don't be talking on the background. Listen for the task, and also coordinate with everybody to know when you should be doing certain things, such as Melody mentioned, like log rolling, and just having shears available and cutting open all the clothes, and taking them off, and all the shoes. Make sure you get the proper exposure. And of course, closed loop communication. Once you get that done, you're like, okay, close off. Or if you feel for any pulses, you would scream out central pulses intact, etc., like that. And when, let's say, you want to do something, obviously pay attention to the severity of the situation. If we're cracking the chest open, if we're doing a ED thoracotomy, probably not a good time to ask if I can make the incision. But if you're doing a chest tube and the patient is completely stable, but just has a large pneumothorax, that's probably a good time to ask, oh, is that something I can try? Or if you're closing a laceration or anything like that, right? So just kind of know everyone's roles. That's the most, one of the most important things is to know what you're doing and what everyone else is doing, so none of the tasks gets missed. And of course, the closed loop communication. I think those are the most important things. Next slide.
Oh, sorry.
Okay.
Can I chime in a little bit as a non-general surgery person that had to spend some time on general surgery as a med student, and then a couple of years of my residency. So I think for med students, it's easy to get overwhelmed. So you can focus on some things that you really are comfortable with, and then just beeline to do that. So as Arlene was saying, I think the clothing thing is just so easy for med students, because that has to come off, right? There's multiple pieces, so you can just cut that off. The other thing that I would do is I just was comfortable doing the rectal exam, because that always has to be done, and I guarantee you no one else is rushing to do it. So
Double glove. Got a double glove.
Yes, double glove. Also know what you're looking for, right? You mostly want to just feel that there's tone when you're doing it. It shouldn't be totally there, a giant hole, because that would be an indication of, someone losing their sphincter tone and a serious injury. But you can do it and then report it to someone that needs to mark it off on the checklist, and they'll really appreciate it.
Okay, cool. So we gave everyone a little bit of a spoiler with this slide already. So now we're going to go into a quick case scenario. And so audience participation is welcome here. You can raise your hand, unmute, or you can put in the chat whatever you're comfortable with. So patient is a 35-year-old male presenting as a level 1 or a tier 1 trauma activation after being struck by a garbage truck. So vitals, heart rate is 130s, BP is 70/40, respiratory rate is 15, and he's sitting at 98%. His GCS is 15. He's alert. He's telling you that his pelvis hurts, and then on your primary exam, you find that there's bruising and abrasions all over his abdomen and lower. There's blood at the urethra, and he's moving all of his limbs. He's got palpable pulses, and he's got no obvious injuries, so no bowel sticking out of the body and whatnot. So before we go on to the next slide, what do we think about the vitals? What stands out to people here? Yep, heart rate, blood pressure, those are abnormal. Low systolic, yes, all correct. And then GCS of 15, is that good or bad? Yep, that's correct. That's the max score you can get. And then basically, based on what information you have now, what do you think is going to happen to this patient? Does anyone have an idea? Yeah, these are all good answers. Definitely should get imaging, definitely bleeding somewhere, and definitely should get resuscitated. Yep, great job. Okay, next slide. Okay, so what happens next is, we get our IVs, EFAS is negative, we get a chest x-ray that's preliminary negative, and then we get an AP pelvis. Click here. Does anyone want to take a stab at what's going on here? Mm-hmm. Something definitely is crooked, yep. It's not a dissociation, but something is definitely not in the right place. So the term we use for this is an open book pelvis. So he's got an unstable pelvis injury. And Jason, you're right, the femur does look abnormal because the entire pelvis is rotated in the wrong direction. So everyone, a good job on catching on those things. So the patient probably sustained some sort of crush to the pelvis from an anterior to posterior force that kind of booked the pelvis wide open. And so the pubic symphysis should not be that wide. You can actually probably drive a Humvee through that. Anyways, so next slide. Okay, so this is an unstable pelvic injury. And then Arlene, do you just want to take it away from here?
Yeah, so the X-ray shows an open book, and so especially with the vitals and everything, you would start an MTP because you're assuming that the patient's bleeding into the pelvis, and then the next thing you would do is to apply the pelvic binder and the Foley placement. So the Foley is a little bit iffy because you do have blood in the meatus, so you do have to make sure that you don't have any like additional injuries before you're placing the Foley. But then obviously you have to consult ortho now that you have this like a pelvic injury. And the purpose of the pelvic binder is to decrease the space. So even if the patient is bleeding into the pelvis, they're not just like having this massive space of area that they can bleed into. And so after that resuscitation, now the patient's vitals are stabilized. So he's taken to the CT scanner and he's found to have like active bleeding into the pelvis, no major like GU injuries. And then he's taken emergently to IR. So stepwise fashion, you would do IR to see if they can embolize anything. Now it's successful, so it's taken the SICU for, and then the ortho would take for stabilization surgery for more definitive treatment. And also, you would have to urology consultation because you do have that blood in the meatus. There might be something that CT may have missed. So you do want a urology assessment as well. In case that the vessel embolization is unsuccessful, then the next thing you would have to take the patient to the operating room and pack the pelvis, which makes it basically just, again, it also decreases that space as well as just control and increase like coagulation and control that bleeding from that aspect. I think there's a question on clarifying why the Foley was placed. So initially, if let's say the patient does not have blood in the meatus, you put in a Foley because the patient is bleeding, has unstable vital signs. You want accurate I's and O's. There's a lot of reasons why the patient's not having urine output. Without the Foley, it could be just because they're not going, they could be producing urine and they're just not going, or they're not making urine at all. So if you put in a Foley, then you can assess whether the patient is actually like resuscitated, because that's one of the first like hint to let us know if the patient's making good urine. It means that they're having good circulation. So having accurate I's and O's.
And oftentimes, in a pelvic injury, a serious one, the bladder is encased within the true pelvis, and so concurrent bladder injury or somewhere along that pathway is not uncommon to be seen. And for us as well, we keep the Foley in when we go in to fix the pelvis, just because we don't want to hit the bladder when we're fixing the bone.
Yeah, and also just having blood in the meatus can kind of be indicative of having a urological defect or injury. So sometimes if you put a Foley in a patient that has like blood in the meatus, you can create it false track, or just exacerbates the current injury. That's why you want to make sure that everything is okay before you're putting in a Foley.
So ideally, someone
And that's
probably
why
call urology to this.
urology
Yeah.
probably
Mhm.
would have already been called. Yeah. So what can I do as a medical student in a case like that, right? So you would help with exposure and primary surveys, definitely lock roll, knowing where the things are, retrieving tubes, and not just helping your resident, helping just the nurses and everyone that's involved in general, right? Because our goal is not to just do our job, it's also just treat the patient. And so with like labels for labs, retrieving the pelvic binder, knowing where the blood products and the Foley and all that stuff. And then one of the major things that we really need help with is transporting the patients, because sometimes we may have to stay behind and do something else, put in orders, etc. So bringing the patient to the CT scanner is one of the really good things that as a medical student can help. And also like just closed loop communication. And if the patient needs to like go to the OR, gather all the information, or even dial the phone to the operating room and let the resident know like, oh, OR is on the line, would you like to speak to them? Like that's something that's like very proactive and you can do if the patient is for sure known that it's going to go to the OR. So like I was saying, like as intern and also just residents, we'll be placing orders for x-rays and CT scans and labs and stuff like that. So there's a lot of things that the residents can do. And I think as a medical student, even as a sub-I, there's a lot of things that once you get used to the flow can help out with. So this is kind of like a general slide, but also like what to keep on hand, right? So when I was a sub-I, I jokingly call myself the walking storage room because all my pockets in my white coat is just filled with stuff. And so these are just like some common things. I think Nancy also kind of went over in her other slide. So make sure you have gauze. This is like something super, super simple. Make sure you have them. Make sure you have tape. If you have room, you have all these options: paper tape, silk tape, Metapor tape. Great options. ABD pads, one of the biggest things. Tegaderms, we love Tegaderms. Suture removal kits is also very helpful, and not just when we're removing sutures, when cutting gauze, when cutting anything actually. And then 1 to 2 sutures, only if you're like very trauma heavy or if it's like something that you do on the basis, but other than that, you may not need it. Loop packets, very important, more important than you would think. Cotton swabs and alcohol pads, iodine swabs, and also iodoform packing. That's also something that's very commonly used in, like, let's say any infection, wounds, or anything like that. Drain sponges, Kerlick rolls, and zero form. And to be honest, when you have any like patient-specific dressing care material, like some people may need like a specific dressing or specific tape because they have allergies or anything like that. So that you'll be rounding on these patients, so you should keep them in hand. So it's like, rounds can go faster and your residents will know that you're prepared and know what you're doing. Usually a lot of services that does a lot of like dressing heavy changes during rounds, like let's say like vascular or trauma, they would have a bag that has all of these things that either the intern carry or that it's for like the medical students to carry. If you see that things are running low, restock them. That's always helpful. And also like one thing for vascular, there's always like in the morning, they need to listen to Doppler to just make sure you have those loop packets and the Doppler itself. But usually like the residents, they will let you know like what's needed, but those are the general things to what to keep on hand.
Also, a marking pen or
Ooh,
multiple marking pens to mark patients in the morning.
So so let's talk about identifying, a good sub-I or med student versus someone that's, you know, really excellent and excels, because I'm sure all of you would do great in terms of meeting, like, you know, just like overall being responsible and things like that. But here are some things that will actually help you stand out. So one thing is just like your style and presentation. So it's important to exude confidence, both when you're talking to patients and then also your own team members, right? Because your team members need to trust you. Now, for those of you that are more junior, maybe you haven't had that many direct conversations with patients yet, but you'll see, you know, even for myself as an attending, I have to try to exude confidence because I want to make sure my patients can feel comfortable about their care, and trust that I know what I'm talking about. And the same is true when you're talking to your own teammates, meaning the residents and attendings. I'll give a little story, which is when I was an intern, and it was like my first day on as a plastic surgery intern, and it was a really busy day. We had, you know, a bunch of discharges, um, and a lot of things to do, and it was a crazy day. And at the end of the day, I had gotten everything done. All the patients that needed to be discharged were out. I delivered good care, and then I, you know, obviously updated the chief resident and everything. And one thing I remember is that one of the mid-level residents pulled me aside and said, "Hey, I know you're working hard and you're trying to do a good job, but when the chief resident asked you a question, you looked like a deer in the headlights. You looked unsure, and you can't do that." And I think that really solidified in my mind and just helped me realize the importance of how you present things too. It's not just the content, which we already kind of talked about. It's also how you present it, because at the end of the day, they're not going to be able to, they may not have time or want to like fact check you, things like that. So they need to feel really sure that you are sure, and that experience really showed me how important it is to look confident so that people can trust you, and that way they'll really see you as a team member. So um, I think that in general, especially for people of Asian descent, right, like we're very used to trying to be respectful of we're taught culturally a lot of times to be respectful of hierarchy, and you know, to be deferential or respectful, you know, and you can still do that and definitely be respectful, be professional, but remember that you are a team member. So you need to speak with confidence, and something that you can do to exude confidence, even if it's your first day and you're not sure. One thing is to make an effort to speak louder, because when we're a little bit nervous, we tend to talk more quietly. So make an effort to speak louder, especially when you're in the OR also, when there's a lot of noises, you know, from you know, different machines and beeping and all that. You need to speak louder so people can actually hear what you're saying. It's very rare to be too loud for a med student. So try to speak louder, especially for women. You know, this is like maybe an unfortunate thing, but in general, I think people like a slightly lower tone sometimes is perceived. That's a whole question that's a topic for a whole nother day, but that is often perceived as, you know, maybe like having, you know, more gravity to it and more confidence. So you can consider lowering the pitch slightly and avoiding uptones, right? Like uh, um, not like no, don't end every statement like you're asking a question. The patient is doing well. Is that a question that they're doing well? Patient's doing well. Patient is doing well. You know, end your statements. Patient's going home today, or patient's going home today. You know, you can say that same exact sentence with confidence, and just try to stay calm. And you know, yeah, ironically, the presentation part also matters a lot in how you're perceived as a med student and as a resident. And maybe that's not fair, but that's, you know, it's just a really important part of what we do. Next slide. Okay. Another point is outward appearance. Again, I don't think this is necessarily a fair point sometimes, because everybody has different styles, and why should you know, your knowledge and the content should matter the most, right? And yet, you know, people unfortunately do judge people on appearance. And you know, I'm a plastic surgeon, so maybe maybe the faculty on my service were more judgmental, but I actually got a negative comment when I was a resident and on general surgery. I remember I was in R2, you know, on like crazy 30-hour shifts, general surgery at a county hospital. And on my feedback eval, the attending wrote that my hair was messy. And it's like, you're working so many hours and you would think that that is the least of people's concerns, but it's not, right? Like you do have to try to, because when you look more put together, people, it's again a perception thing that may not be fair. That's a topic for another day, but people do judge people on that. So I've seen faculty comment on students' hair and people saying, oh, so and so needs a haircut. So and so has, wears way too much mascara, which I don't think that's right. I don't think that's right that people make judgments like that, but it's there. So especially when you're doing like a rotation sub-I, things like that, we're trying not to have appearance that's going to be necessarily controversial. I'm very supportive of everyone having their own style, but for the purposes of something that unfortunately is very judgmental, like medicine, you may consider that, when you're doing certain rotations, especially audition type rotations, having, neatly groomed hair and a haircut, you know, in general, hair color that is within the range of natural hair colors, probably not the best time for really bold colors for a lot of specialties that are more conservative. Makeup, and a lot of times, again, this is not something that I think is necessarily fair, but sometimes like maybe a small amount of makeup gives the perception of being put together. I'm not saying that you have to, but and then similarly, nothing that's too dramatic. That said, I definitely know, female residents that have chosen to do like very, very bold makeup, and all power to them. But just know that unfortunately, sometimes people have certain judgments, and that's unfortunately not something we can take away in medicine. That is, which is in general, our field is very focused on perceptions and people's, personal evaluations of you, which can be affected by bias. It's always important to use professional language, right? So even if you are, if you have a great relationship with the interns and residents and attendings and everyone is very friendly, you want to make sure that you still aren't overly familiar. For example, I remember we had a med student that would text updates, but then would use like a ton of emojis in them. And that's fine if you're texting your friend, but if you're texting your chief resident or an attending, like, you know, maybe not doing like lots and lots of emojis, for example. And have confidence, still be respectful of the hierarchy, but just again, remember that you are also a team member, so you don't have to make yourself that small. This is something that I think that, again, people of Asian descent sometimes tend to do, because a lot of times we're taught culturally to be humble. But remember, you don't need to be overly humble, and this is going to be true for your rotations as well as interviews. Like I've literally seen students that, for example, we had a very smart and wonderful med student that went to Harvard, right? And great schooling. And so, some attendings would say like, oh, wow, like, oh yeah, you go to a pretty bad school, right? Like just sarcastically as a joke. And then the student said, who's, very humble, was like, oh yeah, haha, like I don't even know how I got in there. And again, there's no need to kind of put yourself down, and be self-deprecatory, because, he actually was, a great student, deserved to be there. So it's okay to handle compliments with, just graciously, with confidence, and say, yeah, yeah, I'm having a really great experience there, or, yeah, yeah, it's been a great environment. I really enjoy it. Something like that, where, you're not bragging, but it's okay to be confident. Next. Okay. Interpersonal relationships are so important. Be friendly to everybody, including staff, the admin people. Everyone can and work together. So, you would think that, maybe that the residents or attendings don't know if sub-Is or students are mean to each other, but people absolutely see it. And, you know, and remember that, when you're on service, it's so important to work on a team. So people will quickly weed out people that are not good at working on teams. When I was a sub-I, I remember there was another sub-I that was pretty rude to me. Like he would put me down. He would like pimp me in the OR and trying to pimp me in front of other attendings and things like that. And I thought that no one noticed this except for me. But at the end of the day, when it came down to interviews, I got an interview at that place and that person didn't. And then later on, I had a conversation with the chief resident at that program, and they were like, "Oh yeah, like he was, terrible." So it was just really interesting and eye-opening to me that people could see that. And then obviously, when I was a chief resident and senior resident, I very quickly saw these types of dynamics among students. So just remember that everybody can work together, and people really like it when you show that you can work well together with other people. And remember that the most important person to believe in you is you. So sometimes people may say things that are critical. This is also true for when you're a resident, that, somebody might think or act like they think that you're really dumb, like, oh my gosh, you don't have things together, whatever it is. Just remember that, um, the most important, like, just focus on the work that you actually do and what you bring to the table. And at the end of the day, residents and attendings, they're just people and they're stressed and they have their own baggage and things like that. So do not internalize any of that. And keep in mind, relationships may change over time too. Like I've had some experiences where I think I didn't start off on a great foot with some attendings and then ended up having a great relationship with them later too. So just always, focus on who you are and yeah, and just have confidence in that.
Yeah, and just to kind of piggyback off of that, just be confident and be respectful when you like first joined. And I say that just because residents may look like they're very scary. A lot of people have told me that when they first met me, they think I'm like the worst person in the world. It's just because we're tired, especially when we're post call and you see us, we have like our resting bitch face on. Like don't be like scared or anything. Just approach us. We're at the end of the day, like Nancy said, some of the things don't internalize it. It's just us like talking about expressing how frustrated we are, not with you specifically as med student or sub just of the situation. And I think that's easy. I think when I was a medical student, I was like always like kind of trekking very lightly around residents, but I think once you kind of get to know, especially when you're in a team for a long time, when you get to know these residents, like I usually just ask them like, what do you think, things like that. At the end of the day, we're working as a team, and if you're helpful and you are eager to learn, like you are there to learn, we try to teach you as much as possible. Just don't get discouraged if we look like we are in a really bad mood.
Yeah, great points. And I think the other thing to think about too, I as a med student, I never thought about kind of like how the residents themselves were doing and the attendings, but keep in mind, like everyone's stressed out. The residents, they are also being evaluated and, they're being held accountable for their performance too. So keep in mind that, yes, residents want to teach you and they want to show you things and things like that, but you don't know how that resident is doing. They may be stressed about how they're being evaluated too, or maybe they needed to suture more to show the attending they could suture more or whatever it is, right? So don't take things personally, and and definitely as the more you help out the team, the more you're taking work off of their plate, so they're available to teach you. Um, but I think an important mindset shift is that you're not just there to receive teaching. You're a member of the team helping with care. And yeah, again, that mindset shift goes a long way. So expect that when you're a resident slash also when you're a med student, that you're going to be working long hours, you're doing significant self-study, and you know, just know that it's almost a 24/7 commitment, but you have to take care of your mental health because so much of what we do is mental health. So, so remember to take care of yourself, whatever that is, with boundaries, having some, hobbies and activities outside of work in moderation, but you are going to have to work a lot. So just expect that. I'm also a big advocate of mental health like therapy, which I think is helpful for everybody. And I didn't even start to start therapy until I was a resident. And it was immensely helpful. So, look out for resources at your hospital for that. So it can be really helpful. And sometimes family or significant others might not really understand the demand on you. So you just have to help them understand. There's no way around it. Okay. And yeah, I think medicine and surgery in general is just inherently crazy making. So again, big advocate of just taking care of your mental health. Sticky situations, never lie. So another story from my intern year, right? Like just focus on just doing the work. So for as an example, I think the tendency when we get blamed, because that's going to happen a lot, right? When you're working on service, um, is to try to explain to someone how you actually were responsible, you actually were knowledgeable. Um, and but then when we try to explain that to someone, it ends up sounding like excuses, right? So one story I have is, I was told very explicitly as an intern, hey, this wound vac is very important. This needs to stay on suction all the time, right? It cannot go off suction. So yeah, I definitely made sure it was on suction the whole time. But then overnight, I wasn't there. I had signed out to the overnight intern, and then, left and then come back. And in the morning, it was off suction. And I got yelled at so much because, my team was like, I told you it's not supposed to be off suction, blah, blah, blah. And so, what could sound like excuses is like, oh no, I tried to, I told the intern, I told the overnight intern, like I didn't mess it up. You waste a lot of time by trying to make excuses. I think the best way to handle someone being mad, which sometimes they're not directly mad at you, they're just mad about the situation and they want to figure out how to fix it. The way you can calm that person down is to focus on the problem solving aspect, maximum one sentence to explain your side of the story. So for example, maximum one sentence. I, I, s- I signed it out to the overnight resident before I left. But then immediately skip to how you're fixing it. I'm going to fix the wound vac right now, and then I'm also going to talk to the nurses to figure out what happened and make sure that it doesn't happen again. Like at that point, that's all you can do, right? So don't waste a lot of time talking about, how it wasn't really your fault and things like that. People don't really care. They just want to focus on fixing it. And if you can at least fix things, they'll appreciate that. And then same for if you don't know, like we always want to know things or we want to have the right supplies and things like that. And if you don't know, don't lie or say, oh, don't lie and don't pretend that you know. Um, just say, I don't have that. I will look it up right now. And then go do that. You know, that's all. People just want the problem fixed. Okay, next one. Okay, and then next slide, horror stories, what not to do. Okay, that was just one slide. I think I'll just share one quick horror story then. So it's always important to be accountable and available and accountable. So one horror story that I have is an example of when I was a resident and I was at another hospital, very busy, and then I was on call at the main hospital. So the team at the main hospital was signing out a case where someone had a huge trauma patient scalp laceration, and attending was, waiting they were like, oh, the patient's totally unstable, but the attending is waiting to help close this scalp laceration. Okay. And once the patient is stable, we're going to go do that. So I said, okay. And then the sub-I that was on at the time texted me and said, hey, can I help you with this laceration repair? I said, sure, that's great. That's great that he offered to do that. And I said, okay, well, I'm on my way over, but with LA traffic, it was like an hour before I got there. So I said, okay, I'm okay. Well, I'll meet you at the ICU when I get there. I'm driving now, but it was like an hour before I got there. So when I parked and and it wasn't that late. This was like 5 p.m. or something. When I parked, I was going to text him to say, hey, I'm here. Let's meet. I saw there was already a text from that person that said, "Oh, yeah, I just decided to head out. it's 5, so I just decided to head out. Um, and that was, very annoying because, if you offer to do something, you need to follow through. If it's late and the resident excuses you and say, you know what, it's late, why don't you go home? That's fine. But um I wouldn't excuse yourself. I wouldn't excuse yourself just without discussing with anybody. And by the way, he didn't discuss with me. He didn't say, "Hey, I have this other thing to go to." He said he just FYI'd me that he wasn't there. Okay. And so okay, whatever. But then what's worse is then I went up to the ICU, and then instead of the patient being totally unstable like I was told, the patient was still intubated, but totally calm. They were actually decreasing the vent settings, like probably going to be extubated soon. And then worse, when I went to examine the patient, it had already been stapled by the trauma attending. So it was closed, completely hemostatic. Um, and had been so for hours. It wasn't like they just did this, because I talked to the nurses and it had been that for hours. And there was an attending waiting in the hospital to close this patient, but it was already closed, already taken care of. The patient was stable. And it would have been great if the med student that was physically at that site could have rolled by, the patient to even see what the situation was. That would have been excellent. Um, I don't necessarily expect people to always do that. It would be excellent to do it. But then on top of that, they just excuse themselves anyway. So there were just multiple things wrong with that scenario. And that was a scenario that, yeah, I normally am very supportive of med students, but that was a scenario that I did bring up to, the chair, because like the attendings, they always discuss with residents about sub-Is. I do think that directly impacted his ability to match, and obviously he didn't match at our program. So, so that's a horror story. Don't do that. Those multiple points of not the things not to do. Okay, next. And then for studying, I think for students, it's hard to prepare for surgery. So I think the resources have gotten a lot better over the years. So, one thing you can do to prepare for, you always have to prepare for cases. There's a textbook on the overall topic, but a lot of times textbooks do not have necessarily the step-by-step of how to do the procedure. It's just like a general discussion of that illness or that injury or indication. So it's good to read textbooks, but you're going to need more than that. Definitely have an anatomy atlas so that you familiarize yourself with the anatomy. But specific to cases these days, there's a lot of resources for videos that you can watch. So I would try to watch multiple videos about whatever surgery you're doing. And these days, there's also more and more videos on educational sites or like the society site for certain specialties. And then an excellent resource is PubMed. So if you're preparing for a case, I would read, let's say it's the night before, at minimum, like 5 journal articles on the case. And medical literature is just such a great way to prepare for cases, because a lot of times there's technique papers, papers that are like, here's the standard way to do it, and here's how we're doing it better. Even though that may not be the technique that your attending is using, if you read multiple ones of those and you read the methods section, you can kind of piece together, well, what are the general steps of this operation? And you also get to know, well, what are the things that are problems for this surgery? Like, for example, if they're talking about, here's a safer way to avoid nerve injury for a certain surgery, you'll be able to know, okay, well, nerve injury, this type of nerve injury is a concern, or here's a way I can get better aesthetic outcomes. You get to know what are the main questions for that type of surgery. And I think that in general, attendings and residents are very impressed if you show that you have an understanding of what are the latest things in the field that people are concerned about for this surgery. And you can also have a discussion with the attending about, hey, what groups are, there's a paper or presentation, where people are trying, whatever technique. It leads for really informed discussions. Some of these journal articles will have links to videos, so that's really helpful. And then you'll also see either reviews or outcomes papers. Again, that's really helpful for just knowing what are some common complications that might occur. So by knowing this kind of information, that already prepares you for PIMP questions and things like that. And another thing that I think is helpful is looking at operative reports. Obviously only access it if it's allowed by HIPAA, but if you see if you can get a sample report of that surgery, it's such a great narrative for the steps of the surgery. And you can always go back to, and if it's a patient you already worked on, I would look at the op note and familiarize yourself. And that way, the next time you have that kind of surgery, it also helps you to see how surgeons dictate things and what the key steps are, because there might have been something you missed when you were in the OR. And then in terms of studying, take copious notes. Back in my day, maybe now too, people would use, carry a little traditional notebook around. But I realized during residency, I think an electronic system works even better. These days, there's all sorts of, there's even some kind of virtual sort of notebooks where it's easy for you to scan pages in. You can always like use your phone to take a picture and scan it in. I think an electronic system works great because I used to use a paper notebook, but then it's hard to find your notes. So you really want to organize it in a way where you can quickly search for your notes later, say by keyword or topic. You can consider Google Drive. I used to use Evernote. It used to be really great in their free version. Now they keep popping up things that tell you to pay. So it's changed a little bit, but just look for a good system that helps you organize notes, say by topic, and in that you can paste the body of an op note, obviously take out any PHI in there, but you can do op note, and then whenever you're in a case, I would practice writing down in stream of consciousness style, everything about the case. This is going to be important as a med student and as a resident. What was used, literally by very granular details? What was used for prep? How was the patient positioned? What instruments were you using? And how was the patient draped? Write down every single step that you remember. And I guarantee when you're starting out, you're not going to have a lot. You're going to realize as you start writing it out, you're going to have major gaps. You're going to have, you're not going to, like, what suture was used. You're not going to remember a lot of details. But over time, especially if you do a surgery more than once, you'll be able to fill in more of those details. And then as you fill that in, it's also a great starting point for a conversation with your resident or attending, because you're testing yourself in terms of how much you recall about the case, and you can, and so you can discuss with them again and realize like what parts did you miss. I'll say as an attending, this is also going to help you for the rest of your life too. Like I still look at my notes as a resident or as a fellow, because sometimes if there's certain cases you think you're going to remember based on immersion, you're not going to. You're not going to remember what suture was used. You're not going to remember the exact positioning, but you will always have your notes if you save them. So I just wish I took more notes even, but whatever notes I have are helpful. And then one barrier that I had for taking notes is like, you're so tired. There's no time to like make nice little note sheets for yourself. One thing that you can do also is voice recording, which I didn't really do until I was a fellow, to be honest, but I wish I had done it more earlier. So as a fellow, I would do some voice recordings on the drive home. In LA, we drive a lot. And I would do voice recordings. And these days, like there's even great AI that can transcribe that for you. So at least you can get something on there. And that is just so helpful for preparing for cases, or if you have a similar case with that same attending or a different attending, you don't have to like restart your studying every time.
Hey, Nance, I think we have to leave some time at the end for questions in
Okay.
the audience.
Yep.
You want to wrap up
Okay.
real quick?
Yeah. Yeah. So we're done. So that's just an example of my Evernote of like random stream of conscious notes that I would write for myself, for like how to set up cases or like what the local was, things like that. And you can like stick links in there. You can put papers in there. Yeah. Good. Okay. And then always make sure there's never any excuse for not studying. So, and even if you get thrown in a case last minute, literally take 5 minutes to even just Google something real quick. Like go to the bathroom and just look at something on your phone for 5 minutes, because anytime you think that it's better, oh, they need me to retract. No, they don't need you that much. Like give yourself 5 minutes, because the times that I didn't do that, it was terrible. So, and you'll see that. So just give yourself at least promise yourself you'll give at least 5 minutes to yourself if you get thrown in a case last minute. Yeah, we can wrap up. And if people have questions, please put them in. Yeah, and surgical skills, again, you're going to need to practice that on your own. So I recommend getting instruments online or a surgical knot tying kit. This is something I didn't really do that much when I was a junior student or resident, but now looking back, I do think it's extremely helpful because you will get judged on, you don't have a lot of opportunities to practice. And the better you are, the more opportunities you're going to get. So you can't be doing things for the first time in the OR. So you need to practice on your own so that you're as good as possible before you get that opportunity. So I would definitely invest in some equipment like this. Okay, and then, yeah, if people want to chime in about any resources for their specialties, but we have on the slides, we have some resources that were helpful for studying.
Yeah, so for clerkship, if you're in a general surgery clerkship, I think most people have to go through DiVirgilio's surgery case-based clinical review is a very good option for just for you to study. Surgical recall is also really good. It gives you like the key steps and everything. Stabistance more advanced, is more for like residents and also Fisher abscess review. I don't think that's something that like a sub-I or a med student should invest in, but it's definitely something that's really helpful. And of course, my favorite resource is YouTube and Google. Like if I have a question about a case, I would just look up like, also they have like different styles, right? Like an out laparoscopic approach, an open approach versus like a robotics approach to like same thing. YouTube is a very good resource.
For ortho, if you're doing your rotation, start with ortho bullets, look at videos on VuMedi, and then surgical exposures, just take a screenshot of this page. You'll figure out what you like.
All right, and in our last few minutes, we'll just open it up to the audience for a Q&A. And while you're doing that, also, if you could fill out this feedback form for our speakers, that would be amazing. Yeah, we'll open it up for questions.